First, to begin with, you all know that bacteremia is nothing but presence of bacteria in the blood. That's a very simple definition. We're not going to discuss anything further. And if you look at the epidemiology of bloodstream infections, it could be either primary or it could be secondary. What do you mean by primary? Primary means usually most of these infections are going to be related to the IV, intravenous devices like central veins, or even a simple IV cannula sometimes can induce a bloodstream infection, even though it is not very common. And coming to secondary bloodstream infections, usually the infections are going to disseminate from other sites. Like, for example, you can have a GI infection, that is gastrointestinal infection, or a GU infection, that is genitourinary infection, or a lung infection like pneumonia, or probably a skin infection like abscess, and that is causing a bloodstream infection. And then we have some other definitions as well, like we have something called community-acquired bloodstream infections. So that tend to occur within 48 hours of hospitalization, or it's going to be seen in the outpatient. So this is what we call community-acquired bloodstream infections. Then we have nosocomial bloodstream infections that typically occurs after 48 hours of hospitalization, just like your nosocomial pneumonia. Then we have transient infections. Usually this is not very important, but still in these cases, the patient will be asymptomatic and it's more of a self-limited bloodstream infection. Like, for example, during toothbrushing, when you're being harsh on the gums, it might push bacterium into the blood. So that time it can cause a transient bacteremia. It's not a problem in many patients, but in patients who are having defective heart valves, so you might result in endocarditis. Okay, so one of the important reasons for endocarditis is Streptococcus viridans group, and that is usually due to poor dental hygiene, and it usually occurs the setting of a background damaged valve sometimes. So that can result in transient bacteremia. Usually it's not a problem, but sometimes in patients with damaged valves, it can result in endocarditis if it's repeated. And there is another term called pseudobacteremia, meaning it's nothing but contamination. That's why it's called pseudobacteremia. What are the most common contaminants? The number one contaminant that we encounter in practice is cons, that is Coagulus negative Staphylococcus. Maybe you can think about Staphylococcus epidermidis, but we have different species come under cons. And then we have the Cutibacterium acnes species, previously called as Propionibacterium acnes, currently renamed as Cutibacterium acnes. That's a contaminant as well. And Corynebacterium species, most of them are going to be contaminants, with the exception being the striatum, the Corynebacterium striatum and Corynebacterium jaecium. So these are never contaminants. They're always going to be pathogenic. And most of the Bacillus species are going to be contaminants, except anthrax. You all know anthrax is never a contaminant. So cons, Cutibacterium, Corynebacterium, except striatum, jaecium, and most Bacillus species except anthrax are going to be typical contaminants. You have to probably redo the samples again. So what are you going to do to avoid contaminations? So to distinguish true bacteremia from a pseudobacteremia, it's better to always take multiple blood cultures from different sites. So it's very unlikely that all the sites are going to show the same organism if it's a contaminant. So that's why it's better to go for multiple cultures if you are thinking in terms of contaminant. Coming to some other important definitions, we have something called bloodstream infection, which is nothing but a true infection with pathogen in the blood, because you have to exclude something called a pseudobacteremia. So this is nothing but septicemia as well. Then we have a definition for CLABSI, that is called central line associated bloodstream infection. So which is nothing but a bloodstream infection with central venous catheter in place, and that is occurring within 48 hours without any alternative source. So that is what we call CLABSI. And there is another term called CRBSI, that is called as catheter-related bloodstream infection or central line-related bloodstream infection. So here, the definitions are going to be very stringent because we are confirming that the source of infection is catheter. CLABSI is more of an empirical diagnosis where you're not 100% sure that the catheter is the reason for infection. We are just assuming that catheter is the reason for infection. But in CRBSI, we are establishing the source of infection as the catheter. For that 100%, you have to have quantitative cultures. We should see what is the load of organism in the blood. And we see something called as differential time to positivity. That's called DTP. How fast the reports are tending to be positive. All those things are going to tell you that catheter is the source of infection that you're seeing in the blood. So this is a very stringent criteria. That's why we don't really use it in practice. It's not practical. We stick on to the term called CLABSI, where we believe that central venous catheter is the reason for patient's bacteremia. And we assume it to be the case and we start antibiotics accordingly. So in common practice, we are going to use the term called as CLABSI. So where patient is having a bloodstream infection with CVC in place, that's it. We don't know for sure whether CVC is the reason for this infection or not, but we assume that CVC to be the source of infection. So it's called CLABSI. And finally, we have sepsis. We have already discussed in the fever and sepsis chapter. It is nothing but severe infection leading to organ dysfunction, typically a Q-SOFA score of more than or equal to 2 with a dysregulated host response. So this is what we call sepsis. And that the CLABSI definition, I feel, is going to be the most important. Coming to epidemiology and risk factors of your bacteremia and bloodstream infections. So the epidemiology typically depends on the source. It could be like urinary tract infection where it can result in E. coli bacteremia, or some host risk factors are there. So it can be healthcare exposure that can like result in certain infections, or it can be geographical region that can influence like what infection that you're dealing with, or it could be the antimicrobial resistant rates in your hospital as well. It could be MRSA or MDR pseudomonas. All these things based on a local AMR, antimicrobial resistance rates. And the most common, this is a very important point for exams also, the most common organism that's going to cause bacteremia in the world is going to be E. coli. The second most common organism that's going to cause bacteremia in the world is going to be Staphylococcus aureus. This is the second most common. But overall, most common organism is going to be E. coli as a source of bacteremia, and followed by Enterococcus species. These are the three most important, but I feel like E. coli, Staphylococcus aureus are going to be the most important. And what are the risk factors for developing bacteremia? Too young, too old. Both are going to be risk factors. Because of any form of comorbidities, especially immunosuppressive state, like for example, diabetes, COPD, chronic liver disease, CKD, malignancy, alcohol abuse, all these things are going to be serving as risk factors of bacteremia. And as I said, immunosuppressed state, immunocompromised state, like HIV, AIDS, steroid use, transplant patients, neutropenic patients, post-plenectomy patients, all these patients are also at risk of developing bacteremia. Suppose if the patient is having a barrier disruption, like for example, what do you mean by barrier disruption? We have natural barriers like skin, mucosal membranes and all those. If you disrupt them by introducing an IV catheter, so you're disrupting the natural barrier. Or in patients who are intravenous drug users, or patients who are having burns, mucositis, wounds, surgery, trauma. In all these conditions, you're disrupting the natural barrier, especially the mucosal membranes, the skin. So these are disrupted. So bacteria can enter through these areas. So that's usually going to be the risk factor. So age, comorbids, immunosuppressed state, barrier disruption. You can split into 4. Age, comorbid status, barrier disruption, and immunocompromised states. These are going to be the risk factors for infection. So remember, which are going to be more dangerous, your gram-positive or gram-negative organisms? Always it's going to be gram-negative organisms that are very dangerous because they produce beta-lactamases. Gram-positive, at least we have something to do, like Vanco, Dapto, Linezolid, something we can give. But when it comes to gram-negative organism, they produce different beta-lactamases, which gives a lot of headache in practice. So that is why the tailored therapy is going to be very, very important in practice. So in nosocomial settings though, so even though in community acquired settings, it's going to be more of gram negative, or if the patient is having a clear-cut focus like UTI or GI problem, it will be gram negative. But in nosocomial settings, because of the use of catheters like central venous catheters and IV lines, gram positives are going to be very common. So always try to inspect these lines because you can see some signs of infection like inflammation in the area, redness can be there, or you might see pain, tenderness, thrombophlebitis. So something will be there. Always when a patient is having a nosocomial fever, before jumping into conclusion about something certain, always try to inspect the IV lines also, which are going to be very, very important because they could be the primary source of infection many times. And if it's a catheter related, most of the time it's going to be gram positive only. So this is one of the case, Vignay. So 65-year-old diabetic man hospitalized for 3 days for pneumonia, develops fever and chills. Blood culture shows E. coli. Recent urinary symptoms are there. Otherwise, no central venous catheter in place. So whenever you think about E. coli, okay, it's the most common cause of bacteremia in the world. So it can be community acquired or nosocomial, but most of the time E. coli bacteremia will be community acquired because of UTI, that is urinary tract infection, or it can be nosocomial if the patient has developed a catheter-associated UTI, or sometimes it can be nosocomial from GI procedures. But this patient did not undergo any GI procedures or GU procedure, so nosocomial is unlikely. So I'm going to think in terms of a community-acquired UTI in this case. But if there was a catheter in place, it could be what? Nosocomial UTI as well. So likely source, the moment I see E. coli, I must think in terms of urinary tract only. So most of the time, the organism itself will dictate the probable source most of the times. So it all depends on like what is the temporal association? Suppose if this patient has underwent some GI surgery, gastrointestinal surgery, then I would have talked about the GI source. If this patient has underwent a genitourinary procedure or a catheterization, then that could be the probable source. Okay, otherwise I'm going to simply E. coli means it's always going to be UTI only. There could not be any other source in this patient.